Welcome everyone to our seminar today, Living with Myeloma in a Rural, Regional and Remote Setting. To begin this seminar, we would like to acknowledge the traditional custodians of country in this Turrbal country where I am today in Brisbane and throughout Australia, and recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. This seminar today has been put together because Myeloma Australia acknowledged that the experience of living with myeloma is very different in the regional, rural and remote setting. There's a general acknowledgement in healthcare across Australia that healthcare isn't necessarily equal, but people choose to live in different places, and that's great. Myeloma Australia would really like to reach out to you all and find out how we can support you best. And we recently sent out a seminar and got a fabulous response rate from you all, finding out how we can best support you. And today we have some great speakers who will talk on that topic. We have Dr. Louise Imlay Gillespie from Northern Rivers, who will be talking about living with myeloma. And then we have Associate Professor Kate Burberry from Peter MacCallum Centre, who will talk about teletrials. Karen Young, who's a nurse practitioner in Albany in Western Australia, who used to be a Myeloma Australia nurse, and she'll talk about the practical considerations of being in a regional remote area. And then we have some special guests, Alan and Roz from regional New South Wales, who will have a quick chat about their personal experience. So now I would like to welcome Dr. Louise Imlay Gillespie. Louise is a clinical and laboratory haematologist living and working in the Northern Riviera. She works, not Riviera. She works as a staff specialist at Lismore Base Hospital and provides an outreach clinic to Grafton. Louise is committed to the Northern Rivers and to improving outcomes for regional patients. She is currently the co-chair of NORDOCS, bringing specialists and GPs together, as well as holding the deputy chair for Medical Staff Council at Lismore Base Hospital. She is also the chairperson of the Rural and Regional Working Party within the Australasian Leukaemia and Lymphoma Group that aims to bring therapeutic trials to the regions to optimise patient care. Louise is an experienced haematologist in all haematological malignancy, including acute and chronic leukemia, myelodysplasia, myeloproliferative disorders, myeloma, and lymphoma. She's trained in management of autologous and allogeneic stem cell transplant, and I welcome you today, Louise.
Thanks so much, Tash, and thanks for having me here today. It's great to go through all of this and do some education with patients, which is ultimately why we're here. Hopefully my slides are up and we'll get started. So really today I was going to go through some of the basics of myeloma, what it is, what we can do about it, and then just touch base towards the end about how things might be a little bit different if you are based in the country compared to if you're based in a city. Just for your information, I am monitoring the chat box as we go. So Tash and her team have kindly prepared some questions that we can get through towards the end. But if there's anything that kind of comes up as we're going that you want to pop in the chat box, or if you are one of my patients and you just want to say hello, just pop it, a note in the chat box and I'll keep an eye on that as we go. It'd be really nice if people could let me know where they are in their myeloma journey as well. So if you're newly diagnosed or if you have already had lots of treatment, whether you had MGUS before you had myeloma or smoldering before you had myeloma, or whether you maybe are just an MGUS or a smoldering and not actually having myeloma. So, you know, we're not interactive today, but we can get around that a little bit by using the chat box. So feel free to send me things as we go. All right, so hopefully my clicker should move along. It's being a little bit stuck. I think, just give me a second. Okay, all right, I think I've got it working now. So what is myeloma? So hopefully you're all familiar with this, but basically myeloma is a blood cancer. And a cancer is just any cell that's replicating when it shouldn't be. In the case of myeloma, that cell that's replicating out of control is the plasma cell. So the plasma cell is that one with the big arrow to it on the right. We don't like plasma cells in myeloma, but I do think they're quite pretty. So when you're having to look at the bone marrow, this is kind of the color scheme and things that we get. And the myeloma, the plasma cell really kind of looks like a fried egg. And I think it's just nice to see that and be able to conceptualize it. So what is a plasma cell? Well, a plasma cell is a type of lymphocyte. It's a type of B cell lymphocyte. And the role of the plasma cell is to monitor for infection and produce antibodies against infection when they occur. So like this cartoon on the left, we can see that that's our little fried egg plasma cell, and it's been stimulated with antibodies. And when it sees the right virus, it fires off one of those antibodies to take it out of circulation and get rid of it. In myeloma, what's happened is that instead of having lots of different types of plasma cells that produce lots of different types of antibodies, so we can kind of, again, on the bottom right, you can see there's these Y-shaped structures, and on the left grouping, they're all different colors and different sizes. And that's normal. That's what we should have, is a whole heap of different antibodies produced by a whole heap of different plasma cells that fight a whole heap of different infections. But what's happened in myeloma is one of the plasma cells has decided that it's really good, and it's decided to make lots of copies of itself. And in so doing, it's now only producing one type of antibody, and that's now abnormal. We've got an abnormal plasma cell that's replicating, making an abnormal antibody. And so what we end up with is that grouping on the right of all the green antibodies, where we just have one type. So we now don't call that protein an antibody because that's abnormal. We don't call it an antibody anymore. We use different terms, and different centers use different terminology, but we now generally call that the paraprotein or a monoclonal protein. So that's something that's quite useful in myeloma. And it's often one of the things that tells us it's there. And it's often one of the things that we can then monitor into the future to see how you're responding and how you're going. So when we talk about the paraprotein, I say that's those antibodies, and we're measuring those to tell us what's happening with your myeloma. There's all sorts of different antibodies. So on the right, you can see the 5 different type of antibodies, IgG, IgD, IgE, IgM, and IgA. You can see 3 of them are pretty similar in terms of the structure, but the bottom 2, the IgM and the IgA, are a little bit different. And that does matter. So if you have an IgM paraprotein, they're often quite thick with the 5 prongs, or the IgA paraprotein is often quite active with that kind of formation. So it does make a little bit of a difference if you've got an IgG or an IgA, whether you've got a kappa or a lambda. IgE and IgD myelomas are very rare. So again, they do occur, but not commonly. Some patients won't have a paraprotein. So there's the outside of the Y, there's a little stick that's kind of separate to the main Y structure. And that's what we call the light chain. And that's either kappa or lambda. And we should have pretty much equal amounts of kappa lambda. But again, some patients, the paraprotein is so rotten that the main structure falls apart and we're just left with the light chains behind. So some patients, we're not measuring the paraproteins, we're measuring the light chains. And again, very, very rarely, you can have a non-secretory myeloma, which is all plasma cells and no antibody production. So how does myeloma present? So anemia is the most common presentation, and that's multifactorial in myeloma. So some patients will get anemic because the bone marrow, which is the factory of the blood, is making too many plasma cells and not the good stuff. Some patients will get anemic because the kidneys are unhappy and they're not producing a hormone that asks the bone marrow to make blood. Some patients will get anemic because there's a lot of inflammation and the bone marrow is stressed and then doesn't function properly. Some patients will be a combination of all of those factors, but anemia is probably the most common presentation. Bone pain is something that we also see. So a lot of us have aches and pains, particularly in joints, but in myeloma, we can get bone pain that's kind of in the middle of the bones that might tell us that there's some damage being done to a bone by one of those paraproteins. The kidneys don't like paraproteins. So often those paraproteins can go and block up the kidneys, get in the way of the plumbing, and cause the kidneys to be unhappy and fail. Sometimes patients will just feel unwell generally, and that's kind of above general lifestyle fatigue or weakness. High calcium can make patients pretty sick, and that's often either if the kidneys aren't working or if we do have the paraprotein affecting the bone, that will release calcium and contribute to a high calcium level that can then, as I say, make you feel pretty unwell. And occasionally we have patients that just present non-specifically with really significant weight loss because all of their energy is going into making the myeloma rather than feeding themselves up. I did just put this slide in as say, I don't know if anyone has MGUS or smoldering who are in the session today, or if they had MGUS or smoldering before they got their diagnosis. But there is this kind of asymptomatic myeloma that we consider. So in terms of smoldering myeloma, that's where we've got quite a high level of paraprotein or plasma cells, but we're not actually getting damage from them at this point in time. And we call that smoldering or asymptomatic myeloma. The majority of those patients we can watch, and depending on your risk factors, we'll kind of let you know whether it's imminent, that change to myeloma, or whether we might be able to keep an eye on things for a while. I've got some patients that I was quite worried about a diagnosis with smoldering myeloma who were going on 5-6 years without treatment. And that is critical time. So, you know, if I treated them when I first saw them, they would have had some of the older therapies, whereas now if I were to treat them, I'd be able to offer them much more targeted therapy, which is pleasing. So every year we can avoid treatment can be in the patient's best interests as long as it's done carefully and safely. And then we've got this condition, the monoclonal gammopathy of uncertain significance, which is where we have a small amount of paraprotein and it's not doing any damage. And a lot of those patients don't progress to myeloma, but some will. So we tend to keep an eye on that condition. Okay, so we've established a diagnosis of myeloma. What does this mean? Where are we going to go to from here? So I think it's always good to just think about where we start from and how we can impact on that. So certainly myeloma remains an incurable disease at this point in time. It still remains as something that we're not able to get rid of, but something we want to control over the longest period of time possible. We're working towards cures. So again, there are occasional patients, even with some of the older therapies, that we have treated only once, that have had really long-term outcomes, you know, for a decade or more, who probably are cured for all intents and purposes. But at this point in time, those numbers are very low. So we're not aiming for cure when we treat myeloma, we're aiming for disease control. So there is a lot of change happening in that area. So particularly in America, they're using a lot of the newer agents and combining them all together very early on to try and get higher rates of it never coming back. And I think probably within my professional lifetime, we will move to a point where we are aiming for cure rather than control. But at current, the paradigm, the treatment paradigm remains that of disease that's problematic. So it's causing you problems. And so we treat that and get you feeling more comfortable and get you feeling better. Hopefully we get a good response and we try and maintain that response for as long as possible. But when it comes back, then we restart that cycle. And generally speaking, in that cycling, we the longest responses are going to be out of our first lines of treatment. And then as we get further into the lines of treatment, our responses are going to slowly drop off, and we're going to have less time from each line of therapy. There's always exceptions to those rules. So some patients we just hit on a treatment that just suits them beautifully, and that's always possible. So overall, as the treating hematologist, our goal is to maximize every line of therapy and to minimize toxicity so we can get you through as many treatments as possible, because that's what's going to keep you here for the longest. And all of our therapies continue to improve. So again, when I started as a consultant, I had access to bortezomib and thalidomide and lenalidomide. Pomalidomide was a fairly new drug, and that was about it. Since then, we've had, we'll go through the slide, but we've got access to a lot more medications, and there's a lot more coming. And each subsequent treatment tends to be a little bit more targeted against the myeloma and a little bit more tolerable for the patient. And so we are seeing that impact on survival. So the graph on the left shows you over the decades how that's responding in terms of survival. And you can see as we kind of move from the 1980s up to the mid-2000s, which is the red line up the top, we're having more and more patients survive for longer as the treatments get better and better. And if we look at the most current data, so we had our annual hematology meeting a week or two ago, and the database, the registry that we run in Australia, suggested that for those that are younger and fitter and have had transplants, the average survival's almost 96 months. And for those who are a bit older and not able to go through things like a transplant, it's about half of that at kind of 48 months. And that's, as I say, that's not including all the extra new drugs that we've had added to the PBS even this year. So things do continue to improve, and we are aiming for disease control over years out towards a decade. So let's talk about some of those treatments. So probably the most important thing is the general considerations. Myeloma and myeloma treatment is complicated. The medical students find this hard to understand. Other doctors don't understand what it is and what we do and how we do it. So I think, as I say, it is complicated concepts, and your situation will be quite unique within a fairly complicated landscape. So thank you for Tony for popping in his details. And if anyone, kind of has a look at that, that gives you an idea of some of the complexity that can be contained in just one patient. And if you all put in your details, we would have quite a lot of variation, even if we kind of grouped you up and said, well, this person's had 1 line, this person's had 2 lines or 3 lines, where what you've had in the first line, what you've had in the second line, how you've tolerated that, what complications you've had, is all really unique. So one of the things that's interesting about treating myeloma is really individualizing care to that particular patient. So it is complicated, and that means if you need to go through the concepts more than once, make sure you speak up and say, I don't understand what you're meaning. I don't understand how you've gone to that conclusion or that conclusion. Why can't I do this or that? Ask to see, the consultant or their team more than once. It's going to take more than once for some of these things to sink in. And then I think one of the things that I always try and do from the outset, and then to check in on as we go along, is to say, okay, well, we know that the myeloma has now given you a timeline, a deadline. How are we going to manage that time that we've now got? If we've got 1 year, what do we want that to look like? If we've got 10 years, what do we want that to look like? Do we want to make it as many years as possible, and we go for the highest impact treatments every time? Or is it about other things? Is it about staying at the farm or staying surfing? Is it about looking after your family? Are there particular goals that we need to get through? Is it try and get the kids out of school or to see the first grandchildren? Or is it a balance of both, which is very fair to say, I want as much time as possible, but I want it to be good time. And then, we just balance that as we go along, and we keep checking in on those goals. And when we get to a point, towards multiple lines of therapy that maybe we need to start choosing, then we touch base around those goals again and see which way we want to go. But I think the goals of care are really something that should be discussed quite clearly with your treating team fairly frequently, so that you make sure you're in control of your journey. But with all of that in mind, as it is complicated. If you have gone through and made those treatment goals with your hematologist, then I think trusting your hematologist and your treatment team is also really important. So, as I say, the landscape's quite complicated, and trying to navigate that for any individual from where they are and where they've been and where we're heading, there's not necessarily one way of doing it. So I would trust your expert, your hematologist, to help guide you through all of the different treatments and to get the most out of each treatment. So this is the treatment landscape, which, as I say, it probably isn't exciting to you, but it's quite exciting to me to have so many options, where I had 3 or 4 a few years ago, to have this within just 5 years. And to imagine where we're going to be in another 5 years is quite exciting, because this is time for patients and better quality of life. You'll see I've kind of put some lines and pluses there, and that's to say that whilst these are the main backbones, we can combine different variations of these depending on where you're up to and what you've had and what we access from the government and what we might access on compassionate access. So most patients in Australia who are newly diagnosed will probably start on a combination of bortezomib and lenalidomide with some steroid, which is usually dexamethasone. But depending on your circumstances, you may just get bortezomib or you may just get lenalidomide, but most patients will try and get through a combination of both. Second line tends to then move towards daratumumab with bortezomib. But again, there's exceptions to that depending on what you've had already and where you're up to. And then from there, there's various things that we can use. We've just got elotuzumab with lenalidomide approved, pomalidomide with bortezomib approved, selinexor with dexamethasone's just come on the PBS this year. And then in the background to all of that, we can still use some of our old-fashioned drugs, like thalidomide, which is still a good drug, and sometimes we'll throw that in as an addition, or we might come back to it at the end, and the same with one of our other older drugs, melphalan. Sometimes we use rescue chemotherapy, so sometimes when we're going on 5-6 lines of treatment, sometimes we'll just reset everything with a bit of chemotherapy to buy some time, and then we can move on to some options. And then I've put down the bottom the Belmaf and the plitidipsin, which aren't PBS listed, but they are available on compassionate access. So those are kind of the main things that we can access pretty much anywhere in Australia. And as I say, those are drugs you'll come across at various periods of time. Transplant. So transplant is quite an important part of treatment if you're well enough to have it. So the caveat that we normally use is that an autologous stem cell transplant, which is one that comes from yourself, adds an extra 2 years of survival generally compared to those that don't get it. But of those 2 years, you have a pretty rough 3 months. So the first 6 weeks around the transplant are pretty tough. And then the next 6 weeks, you're kind of beginning to normalize. And about the 12-week mark, 3-month mark, you know, most patients are really beginning to get their feet under them and feel better. So it buys you an extra few years, but you do pay for it with a pretty rough 3 months. Generally speaking, we won't perform transplant above 75 because it's just too hard. So, and as I say, there's exceptions to every rule. If you're 76 and you've had a transplant, good on you. But generally speaking, the older you get, the longer it takes to recover, and the more likely we are to have a complication that could be very detrimental. You know, there is a mortality rate with transplant, even though it's very, very small, but that does get a little bit higher as you get older. Or if we do get a nasty infection or something that takes a bit of time to recover from, then that might limit treatment that we might have been able to give down the track as well. So generally, you know, over 75, we won't use a transplant. 70 to 75, we'll think about it. And under 70, if we can transplant you, we want to, because that is trying to give you the most time possible. Now, Kate's going to talk a bit about teletrials, which is really important. But just to outline the role of trials generally. So probably the main thing that trials adds is extra lines of treatment. So we went through that treatment slide before with, maybe a dozen treatments. Generally speaking, trials are going to add, 1, 2, 3, 4, 5 extra lines. And the extra lines of treatment mean more time. As long as we keep you well enough and the myeloma under control well enough to get you through more lines, then, as I say, more lines equals more time. Generally speaking, patients can have some reluctance to do trials early, but that's probably where we want to do them. So if we are going to use trial options, we probably want to use them within the first 1, 2, 3 lines, not necessarily the first line, but so generally fairly early in your myeloma journey. Otherwise, I find if we kind of leave it to the end of all the PBS options, often we have disease that's relapsing more quickly so that we don't have time to get you to trial because it can take time to set up. And generally speaking, you're more likely to have picked up complications or the like that may also exclude you from a trial. So if we're serious about using trials, it's probably using them earlier rather than later. Generally speaking, trials will give you access to drugs that aren't on the PBS generally. And generally, they're newer drugs that may be more effective at killing the myeloma and may have less side effects. But it is a trial, so they are potentially unknown quantities. Not all trials are created equal either. So when I am interested in utilising a trial for a patient or a patient's interested in pursuing the trial, I think it's really important to always look at it carefully with your treating haematologist and say, is this a trial that's going to be of benefit to me? Or am I just participating in a trial that, is good for the community, for the scientific community, but not necessarily in my best interests? Because we'll have a lot of information about what we're expecting drugs to do and what may be more effective or less effective. And we can compare that to what we do have on offer from the PBS and try and get a feeling for what might be the best move for you. So it's always important to take trials back to your guiding haematologist to make sure it is in your best interests. And then if you do pursue a trial, they can be hard work. You can need to travel quite a bit for appointments. There's a lot of, there can be some additional tests that aren't part of standard care. It can be isolating. Some of my patients got stuck interstate during COVID that really took them back a notch with their mental health. And it can involve some expense. So whilst they try and minimize the expense of being away from home and travel, we all know that it is expensive being away from home just generally, where you don't have access to your veggie garden and friends and neighbours bringing you around hot dinners and the like. One of the other really, really important parts of myeloma care is the supportive care. So in particular, the main reason after myeloma progression that patients pass away is infection. So we are quite paranoid about infection. We generally will have you on different treatments to help minimize or prevent infection. And that can include things like immunoglobulin support, antibiotics, antivirals. We might be giving you growth support like GCSF to help minimize neutropenia that can contribute to infection. And then vaccination. So, we're always looking at what vaccinations we can get in that may help prevent some of those infective episodes. Any of which can be significant, particularly as you get older. Bone care should be part of your myeloma treatment. So bisphosphonates are shown to improve the overall survival, and that's because it helps make the bone healthier, which helps make the bone marrow healthier as well. So those are two very important parts of myeloma care. And then there's other things that may be included. As I say, surgery may be needed if you've got a weak bone that we might need to stabilize. Often I'll use radiation for painful areas to just try and turn off that myeloma deposit and make patients more comfortable. Transfusions might be required. Growth support, as I say, helping the neutrophils along. And then we may need other specialists. So particularly as we get towards later lines of treatment, if we're kind of getting down to maybe the last few years of options, then having input from palliative care that can help minimize symptoms and really make sure that that last period of time looks the way that you want it to. Or, you know, depending on what kind of issues you've had along the way, there may be a kidney doctor that's quite involved in your care as well. So regional considerations, kind of outside of the city. So I think this is like all things. I think there's pros and cons. I love where I live and where I am. But that doesn't mean that it's a perfect situation in any way. So in terms of myeloma care, I think the good things about being in the country is that your expert team, your hematologists and your nurses aren't only experts, and we are, you know, you can go pretty much anywhere in Australia and get excellent care, whether it's up in Mackay, Hobart, Broome, Lismore. You're not really missing out on anything particular compared to the cities. The experts are very well connected and very well educated, and you are getting expert care. But you're also being treated by somebody who's part of your community. You know, and that means that we do tend to go above and beyond for our patients. We do tend to have a very we have a strong sense of responsibility and ownership to our patients. And I think that is a little bit different to the city, where you may be seeing the registrar at times, you may be seeing different consultants, and you may not have that same ownership that you get in the regional area. And as I say, you're more likely to see the consultant for every appointment. There are often schemes to help minimize the financial burden. So say if you are traveling or need accommodation, there are often things that can be offered to help with that. Whereas if you're in a city, you know, traveling from Penrith to the North Shore can be quite an undertaking, but you're not necessarily going to get support with that. That being said, there's not any support for, you know, a farmhand to come look after your cattle for the day, or the things that you do need to do at home. And probably the less good is, as I say, whilst your expert team is part of the community, it is much smaller. We don't have access, you know, in my centre, I don't have a social worker that works in cancer care. I don't have a speech pathologist. I don't have a nutritionist. I don't have a myeloma specific nurse. You know, we are more limited in our expert team. It really comes down to myself and my generalist nurses. But as I say, we do try and fill those gaps and those other roles as best we can. So I think those were most of the things that I wanted to kind of just get some general concepts out for. I think we do have about 5 minutes. I was hoping to leave a little bit longer for questions, but I've got 5 minutes to get through a few questions if there's any burning thoughts.
Thanks, Louise. That was great. That's one of the best descriptions of paraproteins I've ever heard. Always, in every support group, that topic comes up. So I might keep that slide and show it to people. We haven't had that many questions on the chat, but we have had a lot of people saying where they're from and where they're at. And that's great to hear. We recently put out a survey and we did ask for questions to be put to our panelists today. So I've chosen the ones that are specific to the regions. Somebody asked, if you've got a temperature of 38 and you're 2 hours away from the nearest emergency department, what do you do?
So I think that's worth talking to your haematologist ahead of time. If you are kind of that distance, we may provide some rescue antibiotics so that you can start something and then present and see. Or we may be able to quantify your risk a little bit more. So, the thing that we worry about is if you are neutropenic and you do have a high temperature, then yeah, we do need to see you in the emergency department, or you need to call an ambulance so that they can provide direct care to you quickly. Whereas if you're unlikely to be neutropenic, depending on what your treatment is and where you're up to, then the hematologist may put a more sensible plan in place, saying, look, if your temperature is 38, start this antibiotic. If it keeps going up, then you're going to have to go into the emergency department. But definitely a question worth asking ahead of time.
That's great, thanks. Adam asks, hi doctor, you said progression shortens between each line of treatment. What is the average time for the first line of treatment after diagnosis?
Yeah, so good question. It does depend on a lot of factors. So depending on your genetics, what treatment you've had, whether you've had a transplant or not. But on average, for most patients, if you've not had a transplant, probably around 2 years. If you have had a transplant, around 4 years. And as I say, there's a lot of variation within that, depending on if you have a high-risk mutation or if we've used maintenance or not, and how much disease you had in the first instance, whether you've had a good response or maybe a less good response, will depend on the time as well. And generally speaking, when I'm going through each line of treatment, I'll tell patients what what the studies tell us we may get, like 4 years. And I'll say, but I'll expect you to maybe get half of that. Or, I'm hoping to get a bit more than that because you have done so well, or, and I'll try and keep updating my patients on where we are with each line. So definitely, you should feel comfortable asking that question of your haematologist as you go along.
One of our survey people asked, is there a link to chemical compounds used in agriculture and myeloma?
Yeah, so we know that leather workers, farmers, the agricultural industry have an increased incidence of myeloma, but we don't know why or the particular compound. We know the petrochemicals have a definite link. But that's, as I say, kind of if you live around an oil refinery or you've worked in a petrol station, lived in a petrol station, that type of situation. But there is an agricultural link, but we haven't figured out what the element is at this point.
PPE is recommended.
Yes.
Okay. Somebody asked, what are the limitations to getting myeloma treatment in the regional, rural and remote settings? How do you think we can address this? And how do I advocate for myself to improve therapies in these areas?
Yeah, so I think that's a really important question, and something we're always trying to work on. Generally speaking, as I say, all of the therapies I've listed today will generally be accessible somewhere near you, depending on exactly how remote you are. You know, if you're over in Western Australia, some patients may have to travel for a day or two to get some of these treatments, and that may limit what we can do. But around most of coastal Australia, where the majority of the population is, these treatments are accessible. And the biggest thing that we miss out on is trials, because, you know, we don't have as many patients to enroll on trials, and we don't have the staff to be able to undertake as many trials. But that's why we're looking at things like the teletrial models to try and minimize some of that and try and maximize our enrollment. A third of Australia lives outside of metropolitan centres. 30% of the population is outside of the city. So we really need to fix that problem so that we are maximising care for all of our patients. And Kate is going to talk a bit more about that in the next session. In terms of advocacy, you know, have a chat to the haematologist and see what they need locally. But then there's also things like through Myeloma Australia, the ALLG Trials Group. If you're involved in any of those, just always noting how important it is. Writing letters to your federal member can be really helpful, or to your state member. Yeah, those are probably the main things.
Thanks, Louise. I guess somebody else asked then, you know, would there be a choice between having an injection, an IV infusion, or tablets? Does that make it easier when you're going through that decision-making process of treatments?
Yeah, so generally speaking, there's some points that there may only be one, or there's clearly a standout option. And then there's other points where, you know, treatment 1, 2, or 3 are all pretty reasonable. And that's where, when we've got a few good options, often it does come down to logistics. Are we better off using a drip? Would that be easier for the patient? Some patients just want to come in and get some support and see the nurses and talk to their friends in the unit. We can combine that with a consultant visit at the same time, so they're kind of doing everything all at once. Or would tablets be better, so they can travel around in a caravan, you know, and do other things that are adding to their quality of life? Is a combination of some of those things, and can we organise maybe some of the drips whilst they're on the road? You know, there's lots of different options, but again, that's where we need those treatment goals, and then we match that up with the medication therapeutics to come up with the best plan for any given patient. Yeah,
that sounds good. And I guess my last question comes from somebody who's had a stem cell transplant, and they've just come home from a capital city into a regional area and are wondering how they will be supported by their regional centre after going through something very specialised.
Yeah. So generally speaking, the haematologist will be trained in transplant. Often it's something that we will have been doing when we were trained in the bigger centres. And then when they come back, you know, we're very familiar with what that looks like and what they'll be experiencing. And again, the nursing staff get used to seeing it, whether they have direct experience or not. Generally speaking, when I know a patient's going for transplant, then I'll kind of count out the 30 days that they'll be in the city, and I'll plan to see them the week afterwards. If it gets pushed back, that's fine. You know, we make an appointment for the following week. And then once I've seen them that first time, often I'll decide whether I'm going to see them each week or each fortnight, as we get through, as I say, those rough second, the rough 6 weeks until you're kind of feeling more normal again. And as I say, generally speaking, transplant makes you feel bad. Then you get good, but not great. Good enough to go home, but not yourself. And then over the next kind of 6 weeks or so, you get a little bit brighter, a little bit brighter, a little bit brighter. And then all of a sudden you look back and go, oh, yeah, I'm feeling pretty good now. But that can take, I say, about 3 months. And I just hold the patient's hand through that process is the way I tend to do it.
Well, let's hope everyone else out there, all the other haematologists, are doing that as well. Louise, thank you so much for giving up your very precious time to talk with us today. We really, truly appreciate it.
No
We're
worries.
just going for a short break. Thank you. We're just going for a short 10-minute break now, and then we'll be back with Emma and Kate Burberry. Thank you. Bye.
Hi everyone. Last year we introduced you to 38Mate, an awareness campaign that shone a light on myeloma and the 38 Australians diagnosed each week. This year I want to tell you about our new campaign, Joyful Moments. This campaign celebrates all the wonderful things our 38 mates, their carers and our community enjoy. Maybe it's a new hobby you've taken up or an old passion that you've found a new way to enjoy. We'd love for you to share your joy with our community. Maybe you love fishing, swimming, bushwalking, playing music, or something completely different. I've been with Myeloma Australia for a number of years now, and over that time I've met so many wonderful Australians who love doing so many different things. We know that being diagnosed with myeloma can have a significant impact on your life, making it difficult to do things you used to do. But sometimes it's possible to do the things you enjoy, just in a slightly different way. So while we spend a lot of time talking with you about myeloma and all that goes with adapting your life to living with it, we want to take some time out to celebrate all the amazing things that you do when you are being you. Because that's really the goal of everything we do, to support you to spend more time being you. Joyful Moments also fits perfectly with our focus for Myeloma Awareness Month. In May, we will have seminars focused on wellbeing and possibility, reflecting the hope that new treatment advances are bringing in myeloma. We know that at the heart of wellbeing is doing more of what you enjoy and what makes you feel happy. Sharing what makes you feel good may also inspire others to take up a similar interest and spread the joy further. So over the next few weeks, we want to hear from you, your family and friends. Just complete the sentence, I'm a 38 mate and I love, or I care for a 38 mate and I love. And send a photo or video of you doing whatever it is you love to do. Simply email 38mate@myeloma.org.au. We'll then post your pictures and videos sharing joyful moments across the myeloma and wider community. We really look forward to seeing your photos and videos. Thank you.
Hi everyone, and welcome back to our webinar on living with myeloma in a regional, rural and remote setting. My name is Emma and I am one of the myeloma support nurses based in Victoria. Just a reminder, if you have any questions, please submit them in the chat box available below this live stream. Without further ado, I'll introduce our next guest speaker, Associate Professor Kate Burberry, who will be presenting on the topic teletrials. Associate Professor Kate Burberry is a consultant haematologist, Director of Digital and Healthcare Innovations, and Chair Senior Medical Staff at the Peter MacCallum Cancer Centre in Melbourne. Kate is the lead for digital health, healthcare innovations, healthcare research and implementation, and the strategy for building our regional partnerships around Victoria and interstate. Kate is also the Haematology Disease Group Lead for Myeloproliferative Disorders, Chronic Myeloid Leukemia, and lead clinician for hemostasis, thrombosis, and perioperative optimization, including prehabilitation for all patients with cancer at the Peter MacCallum Cancer Centre. Kate is a member of professional societies, scientific committees, council member for the Haematology Society for Australia and New Zealand, and actively involved in the development of expert guidelines and governance structures for both the institution and external working parties, including the European Leukemia Network, Flow Symmetry in Myelodysplastic Syndromes, or MDS. Kate has an active translational research and clinical trial portfolio with a particular interest in MPD, CML, FC in MDS, and the hemostatic endothelial dysfunction associated with malignancy. She has published numerous peer-reviewed manuscripts, regularly represents at national and international scientific meetings, and is a member of editorial boards and a reviewer for numerous journals. Kate is committed to clinical and translational research and the provision of the best care to patients through their treatment journey. Kate will be talking today about teletrials in Australia. Welcome, Kate.
Thanks, Emma. Thank you for your very kind introduction, and thank you so much for including me in this seminar. And people in the audience are probably going, why are you talking about myeloma? And I suppose the other thing to mention to you is I've always considered myself as a haematologist that's like to look after every aspect of haematology, but more importantly, I've been really motivated in terms of overcoming access and quality care independent of geography and architecture and infrastructure. And my passions come from growing up in Tasmania, but also deploying care around regional Victoria. So out of that came the idea of a strategy to ensure trials became accessible to everybody, no matter where you lived. And we know that in cancer care, things aren't always equal. Geography becomes a barrier, travel and logistic challenges that go with geography, but also access. And we're really lucky at a place like Peter Mac, we have wonderful access to clinical trials. But if you live in regional Victoria or regional remote WA, anywhere outside of Perth, access to these cutting edge and innovative therapies aren't always available. So that's what the teletrial strategy is all about. It's not an intervention, it's about a strategy or a network teletrial, a strategy to deploy access for patients so that they can get cutting edge therapy no matter where they live. So without further ado, I'm going to walk you through teletrials and also a proof of concept that we've done to show how well teletrials can work. Myeloma is yet to be executed as a teletrial, but I think is a wonderful disease paradigm, and particularly with the therapies that are available to run as a teletrial. There's a lot of motivation in the space, particularly with haematologists around Victoria, New South Wales and Queensland in particular. So we're looking forward to myeloma being a flagship in the teletrial space. So what this picture shows you is how big Australia is and the disparity in population density demonstrated on the left-hand side, where generally our population is concentrated within the major metropolitan areas and large towns, largely due to infrastructure of professional opportunity, health access and education. But you can see more and more people are choosing the lifestyle change and moving outside of the big cities and the concrete jungle and looking for smaller towns, country towns, seaside towns, etc. And this actually predates the COVID virus that I've affectionately put in the right-hand top column. The move outside of the major metropolitan areas happened well before that. And there's huge population growth that's now spreading around Australia, which is really exciting to see. We have a wonderful and a big country with lots to offer, and people are looking for that from a lifestyle choice perspective. So that means we need to get cleverer and better in terms of deploying clinical care, but also access to these innovative therapies outside of the major metropolitan areas. What this shows you is how cancer care is sitting in Australia at the moment. And we know that the numbers are climbing, and myeloma is a really good example of that. The numbers of people that are being diagnosed with myeloma are climbing. And particularly in older patients where there are a number of comorbidities. And that makes it harder for patients to leave their local environment to come to major metropolitan areas for clinical trials. So this is where it's really relevant. We've got a really vibrant research and innovative community in Australia with lots of advances happening across many different disease entities. And myeloma is a really wonderful example of that. And if any of you were diagnosed more than 10 years ago, you know we had very limited access to treatment in our armamentarium, but now we've got a wonderful plethora of different drugs, thalidomide, lenalidomide, pomalidomide, carfilzomib, bortezomib, many of these drugs that you've heard about. So we've got a really vibrant and innovative community in research driving myeloma, but really it takes time for these drugs to get registered on our PBS for routine access in the community. So we really rely on clinical trials to allow that to come to fruition for you guys in terms of patients with myeloma. Hopefully I haven't lost my clicker, Emma. No, I haven't. Good. My phone just went off. So have we advanced? Not quite. I might need Liam, you to advance the next slide for me. Great. So really, I've said this, clinical trials are a way for us as clinicians and patients to get the best therapies available for clinical care, but it's a really important way of us advancing science and advancing drugs to registration. So when a drug is discovered through a whole, intensive area of research of biological understanding of disease and the drug, and then experimental therapy in the lab to understand how the drugs work and how effective they are, we then need to show that they work in both healthy volunteers and, of course, in patient populations, and they're going to benefit from that. And that takes time. So we really utilise clinical trials to access them early, but also to progress that research so that drugs can become registered on our PBS and available for routine care in the community. So clinical trials not only give you access to drugs, but also progress science, advanced science. They're also a way of recruiting people for jobs. It's also a way of recruiting revenue and expanding healthcare outside of the major metropolitan areas. So once again, a really important way that we advance medicine. Next slide. Thanks, Liam. This is really, I've sort of said this, is Australia is a big country with population diversity, but also cultural diversity in rare cancers. And in fact, it's the rare cancer space that the network teletrials become so important because not everyone lives in the same postcode. So if you want to be able to get the reach that you need to expand novel therapies, but also clinical care, and quality care, you need to be able to get that reach. And so network teletrials offer that opportunity. It's essentially delivering care no matter where you live, who you are, what your socioeconomic status, what your cultural background is. And having worked in Victoria with with much cultural diversity, actually being able to deliver care in their home environment with their own medical specialists is really important. Next slide. Thanks, Liam. So why are teletrials so important? Well, if we look at our track record to date, and I've told you how important trials are, really what we've been able to demonstrate, even in the major metropolitan areas, how ineffective just a single site trial can be, with less than 50% of trials actually recruiting patients to progress it to answer the scientific question. 85% of trials not failing to finishing on time, and trials actually taking a lot longer than they should do to progress. And that really defies the purpose of clinical trials, which is to progress science, progress the drugs, and make them available for clinical use. So we need to become better and cleverer in terms of both recruitment and retention of patients. So it's not just about recruiting 100 patients to a trial, it's actually keeping them on trial for the lifetime of the trial so that you can answer the scientific question. So what I'm going to show you with a proof of concept is how these network trials make it easier to access the trial, but more importantly, make it easier to participate in trials. And many of you in the audience have probably participated in trials and know how onerous and what the commitment can be to complete that trial. Next slide, thanks, Liam. So essentially, what is a teletrial or a network teletrial? I call it growth without stretch. What it actually enables you to do is conduct any part of the study. It might be 5% of the study, it might be 100% of the study at the local sites. So what it is, a network, and we call them primary and satellite sites, but it's not hierarchical. It's essentially 4 sites coming together and saying, we're going to deliver a trial. So if I give you by way of example, it might be a Melbourne site, Bendigo, Albury, Wodonga, and even a New South Wales site. We hope to be able to cross state borders at this stage. And it means that we could deliver all of the activity of the clinical trial at Lismore, where you might live, or at Bendigo, where you might live, rather than you needing to come down to Melbourne, which for some people, like in Victoria, if they live in Mildura, is an 800-kilometre round trip just to be seen by the doctor, have your blood tests, and do the trial activities that are required. So it means that you can have all of that done or part of it done in your own environment. And I think for many of you, if you've been on a clinical trial, to participate weekly, to have a clinical review, blood tests, etc., is quite onerous in terms of the travel involved. So even now, with many of the major smaller towns, they can have PET scans done, even collect blood samples for the more sophisticated tests on the clinical trial. So it allows for much of the clinical trial activity to happen closer to home. Next slide, thanks, Liam. Oh, that shows all the different activity. So what does it mean going forward? There's a lot of back of house stuff that we've needed to achieve for this to happen, in particularly from an ethics perspective, pharmacovigilance, and so forth. But really, we've broken the back of that with this proof of concept in terms of the target TP, which I'll show you in a minute. But what we think we've done is created a really safe strategy that still respects all of the compliance and regulatory ethics, privacy, data sharing, and so forth, for the trial to be delivered exactly like it would be as if you're coming to the major site. So what I said at the very beginning of this talk is it's not an intervention, it's actually a strategy to enable trials to be deployed broadly across wherever you might live. And I think that's the most important thing to say. It doesn't change the way the trial is conducted. It doesn't change the way you participate in the trial. It just allows you to do that nearer to home with your home environment and the local doctors that have been looking after you. I think the other component to mention to you is if something goes wrong and we know people can get infections or a complication, it means that you don't have to then go down to Melbourne or the major city to have that addressed. You can have that in your own environment with your local doctors. So really what we've done is broken the back of all of these regulatory, pharmacovigilance and ethical components that have allowed us to deliver this strategy effectively. Next slide, thanks. So what I'm going to do is show you a trial, which is not in myeloma, but don't be concerned about that. It's agnostic to which disease entity it is, and just show you what a network teletrial can do in terms of delivery of care. So for the purposes of this, by background, what target TP was, and in fact this is relevant for myeloma, is prevention of clots in disease entities. So this was looking at lung cancer and GI cancer that also have really high rates of clots. And for many of you that have been treated with myeloma, you've probably been treated with clot preventing therapy because of the high rates of clots. And what we'd actually developed is, just if you can press on the clicker, Liam, to get the next bit up, is a risk score to profile patients so that we can actually reliably predict if you're at high risk of clotting or low risk of clotting. And what it shows you on the left-hand side is a nice graph which shows a really wide graphical representation of high risk and low risk. That's a really good predictor because it means that with reliability, we can say that you are at high risk or you are at low risk. If you can press the next button again for me, Liam. And what we've been able to show is by measuring two very simple blood tests, which is a D-dimer and a fibrinogen, that we could actually reliably predict by applying thromboprophylaxis in high risk. We only needed to treat 4 to prevent 1 clot. So that was really exciting. But what we needed to be able to do is test that in a randomized controlled study. And that's what Target TP was all about. Thanks, Liam. Next cursor. So what we did is we ran a prospective study. If you go to the next slide for me, please, looking at testing this risk score in solid tumour patients, but this could have easily been myeloma. In fact, we were very keen to have myeloma participate in this, looking at low molecular weight heparin or no therapy to prevent clots. I won't go through this slide in great detail. This was just the study design, but essentially patients were risk profiled. If they were at high risk, they'll either randomised to receive low molecular weight heparin or Clexane or injections in your tummy, which many of you may receive before, or no therapy. But really importantly, we also kept the low risk population that we'd predicted to be low risk in the trial and followed them up. And this is really important because imagine if our risk score wasn't predicting reliably. And in fact, many of the people that were denoted as low risk actually clotted, we wouldn't know that. And many of the other big studies internationally that have done similar paradigms like this have not included the low risk in the trial portfolio. So this was a really important aspect that we kept in to look at how reliably we predicted for low risk as well. Next slide. Thanks, Liam. But this is what I really wanted to show you is actually our recruitment and retention of patients. So the primary site was Peter MacCallum Cancer Centre in Melbourne, and our satellite sites were Bendigo Health, so more than 200 kilometres away from Melbourne, Ballarat, Shepparton and Albury-Wodonga or Border, which was again more than 300 kilometres away from Melbourne. So we recruited these sites to also recruit patients with these disease entities and go on the study. We managed to recruit our patients inside of 2 years, which is quite phenomenal. Most studies would take 5+ years to recruit the number of patients, and there was 300 patients in total, so that was quite impressive. But the most important thing is nearly 50% of the patients actually came from the regional sites. So if we hadn't done this as a network teletrial, 50% of patients would not have been recruited to this trial, wouldn't have had the opportunity to participate on the trial, would not have advanced the trial for the purposes of science and advancement of medicine. So that's something that we're most proud of. And if you see on the next slide, it gives you some details about where these patients were and what the disposition was. If you could go to the next slide. Thanks, Liam. So I like showing this graph because very, very rarely do you ever see a predictive graph where you actually predict for your trial what you hope to accrue and what you do accrue. Generally, what you see is what you hope to accrue and a graph that sags down below in terms of your recruitment. But you can see we're actually able to recruit at a rapidity that we predicted, which was more than 10 patients a month for the most part over the 2-year time period. Next slide. Thanks, Liam. But this is the really important thing. As I said, nearly 50% of patients were actually recruited from the regional rural areas. We had that sustained rapid recruitment, which enabled us to complete accrual actually within 2 years of bringing the satellite sites on board, but 3 years in total. We opened it at Peter Mac for 6 to 12 months before we deployed the network teletrial. But we had really low dropout rates. So no patients actually came off study because the commitment was too much, or it was too onerous, or in fact, the impact of going on a study actually detracted from their quality of life. And we had very, very few withdrawals due to any logistic challenges as well, with only 5 out of the 326. More importantly, you can see the satellite sites were largely more than, or patients were largely more than 100 kilometres and up to 325 kilometres from the primary site. So we avoided a huge amount of travel and commitment from the patients. And on average, most of the patients were less than 50 kilometres from the satellite site. So really retaining care closer to home. And there were no trial conduct violations. So the most important thing from an ethical and a regulatory perspective, we actually completed the trial as we would as if it was all done in Melbourne. Next slide. Thanks, Liam. So, in fact, I'll probably just go to the next slide because I really like opportunities for people to ask questions if we can. This is just an acknowledgement of the team that were involved in the project. But really what I wanted to share with you, and perhaps if you go to the next slide, Liam, I might have it on the next slide, or it might be, I'll come back to it. But really what I wanted to show to you is that teletrials is a tool or enabler. It doesn't alter the trial construct at all. It's an opportunity so that all patients anywhere, any cancer, anyhow, can participate on clinical trials. It also shows you the appropriate time efficient recruitment in terms of almost a multi-centre recruitment of patients to a trial, which enables the success of the trial, which is really the scientific intent, and also drives registration of drugs so they can be used as routine use. It enables research programs. So we built the research programs in all the regional centres, which actually shows you on the Victorian map here. So we've been able to grow the regional centres in terms of their research and trial portfolio. It consolidates resources, so there's less waste in terms of the conduct of the study, and also less waste in terms of individual patients committing to the study in terms of the time that they need to do. It also creates professional opportunity in healthcare partnerships, which is a really good thing. So it means that clinicians in the regional areas can participate in trial programs, professional development research programs. That's good for patients, it's good for clinicians, it's good for health services. It means that we retain all of those clever clinicians in the regional centres because they have the same professional opportunity. It works, and I think we've shown you that with the Target TP, and there are other studies that are now being conducted as network teletrials. And it's also very much a sustainable and transferable solution strategy that could really be done for any trial. And really what I would challenge principal investigators and trial groups and clinical trial units is to ask of every trial that comes across their doorstep, could this be included as a network teletrial to enable success and access? And so what this picture shows you is the network that we've developed in Victoria, and really excitingly, and I know Louise spoke earlier, there's a really motivated group in New South Wales and Queensland as well in the haematology fraternity to actually create networks to deliver these trials. And this shows you here in Victoria. So next slide for me, Liam. We've got some really great now governance committees. So we've got a Victorian Teletrials collaborative approach, which is out of all of the major centres in Victoria that have come together and are motivated to deliver trials through this strategy. And similarly, there is the development in the regional rural networks in New South Wales and Queensland. And WA has also been really motivated in this space as well. Next slide for me, please. And there's also a large national program to really support the development from an operational and a framework to drive teletrials. But really where I think the importance is actually with the patients and the consumers is for them to drive this program and show their motivation in terms of wanting to access not just clinical trials, but early access, quality healthcare, and to be the drivers behind these programs. Certainly for us, when we started this program, a lot of it was driven out of consumer advocacy. So you can't underestimate how important that is. And for all of you to be asking, you know, is there a trial available for me? And is there a teletrial? Can I have this trial closer to home? We're now trying to set up cross-state borders for the teletrials, and particularly from Victoria, setting it up with Tasmania and Northern Territory. But we hope at some stage that we'll be able to become less federated in the way we conduct trials, and trials should be able to conduct it Australia-wide through this networked approach. Next slide. I think it might be my last slide, Emma. I don't really need to show this, but just to show again, there are motivated programs to try and overcome disparity in access and quality, no matter where you live. And last slide, I think, Liam, coming up next. Yeah, thank you. And I'm happy to answer any questions, obviously, Emma, related to network teletrials or how this might work for myeloma, or any specifics about the trial that we've run.
Thank you so much, Kate. It sounds like an incredible program and tool, and thank you so much for being such an advocate for our community living in the regional, rural and remote areas of Australia. We're such a large country, and we have so many patients, you know, in those areas. And I know even just from personal experience in my clinical role, but also my role at Myeloma Australia, that travel is, it's such a big factor in patients accessing treatment in general, but particularly trials that require, that extra monitoring and tests, etc. So thank you so much for that presentation. We don't currently have any live questions at the moment, but we do have some from our survey that was sent out a few weeks ago. So the first one is, how do I access clinical trials and specialist referrals in capital cities?
So good question. What I do, it might be easiest if I answer what I do at Peter Mac. It's not going to be the same for all major cities. So we welcome, and many people contact us directly through, social media, internet pages, and come to the lead. And so what I try and do as a specialist at Peter Mac, and I'm the disease group lead for MPN and CML, is set up a meeting. And so the patient just needs a GP referral to tap into us. But I set up the meeting specifically, Emma, to do exactly what you just articulated, is to provide a level of support so that they can retain care closer to home. It's not about them being referred to then have ongoing care at Peter Mac. It's about, how do I tap into your resources, your opportunity for trials? And so the most important thing I think clinicians need to do at the major metropolitan areas is actually see themselves as that navigator. So if a patient came to me by way of example for myeloma, my prompt would be then to say, right, well, where are you at in your disease trajectory? What therapies have you had? What have we got to offer at the major metropolitan area, either through conventional care or through clinical trials, and tap you into the trial program that exists so that you can still have all of your care like you've always done closer to home, but where there is a time or a place where an opportunity happens that isn't closer to home, you have that direct avenue. And if I think about the area that I work in, such as MPN in particular, which is a rare cancer with very limited therapies, that's often the role that I play, is when a trial becomes available, that network group of people that have tapped in, I can go back to their local clinicians and indeed the patient and say, we've had a trial that's just opened in this area that may be relevant for you. So I strongly advocate that people do use those networks to tap in, but see it as not a transfer of care or a co-care arrangement, but rather being able to tap into those resources and clinical trials that might not be available in your region. And I think that gives a layer of advocacy too, Emma, because it encourages us as major metropolitan specialists to be aware of patients and clinicians and access out in the regional rural community.
Thank you. The next question, what are the obstacles to clinical trials being conducted in regional and rural areas?
Yeah, it's largely due to infrastructure. So at Peter Mac, we have more than 500 clinical trials, a whole body of staff, clinical trial nurses, data managers, etc. If you go out into the regional areas, they may have one staff member that's canvassing all of the clinical trials in the cancer space. So there is a people and a resources and an infrastructure challenge. And that's where I think the network teletrial overcomes all of that. You don't need 10 staff. You just need a connector point locally and a connector point at the primary site. And that's why this works. And that's why I call it growth without stretch. It's endogenous growth, but also what it also does is it enhances your ability to recruit people to the region. If you've suddenly got a vibrant clinical trial unit with a growing portfolio of trials, you're more likely to get clinical trial staff going out to the regional areas to have that lifestyle change that they want, and professional opportunity in a smaller place to progress clinical trials. So really, it's not because the patients aren't there, it's not because the clinicians aren't motivated, it's not because the hospitals don't want it, it's the infrastructure and people and resources that limit the ability. And that's where I think the network teletrial is a great solution.
Yeah, and as you said, that's shown in the trial that you did with 50% of the trial population coming from regional, rural and remote areas. So, we do have a few live questions coming through now. This is one from Tony. Can I get on a CAR T trial from Hobart?
Great question. So what do we think about in terms of clinical trials and those that are appropriate to be networked? It comes down to site capability, but it's not just conducting of a trial. And I know, Tony, you're not just talking about CAR T in trials, but there's also non-trial CAR T. So I'm not going to focus specifically on CAR T, but I'm happy to to answer that question if it needs to be. If we look at any trial, say in myeloma or in any other disease entity, it comes down to site capability and what can be done locally and what needs to be done at the central site. And that's the beauty about the network teletrials. It doesn't have to be an all or nothing strategy. So it might be that actually only 20% can be delivered closer to home and 80% needs to be done at the primary site, but it still makes it accessible versus 100%. So I'll give you some live examples. If you've got a trial that, say, was using lenalidomide and carfilzomib in a combination for the first time, and Hobart or Tasmania, just because Tony's from Tasmania, they've got experience in all of those therapies. Maybe 100% of the conduct of the study can be done in Hobart, and it's a true network trial where all of it is done closer to home. When you've got a more specialised therapy such as CAR T, or say a bispecific antibody T-cell engager, or BiTE as affectionately called, where the local site doesn't have the infrastructure and the support services set up to deliver CAR T, it would not be in the patient's best interest to actually have that acute period done. But maybe the lead-up phase, and once the acute period's over, and the post-follow-up phase can be done closer to home. So really it just comes down to that communication between the centres and the clinicians as to what things can be done locally versus what things need to be done at the major site.
We have a question from Phil. What clinical trials for myeloma are currently available regionally, and are they using isatuximab? So I guess, are any myeloma trials available through teletrials currently?
Currently, no, but there's been a lot of discussion at a level of our cooperative trial group, which is called ALLG, and people may have heard about it. And it's probably the major cooperative trial executor in Australia, and certainly for haematology. And so there is a lot of interest with the PIs to start looking at network teletrials, particularly in New South Wales and Queensland. To me, myeloma is a great paradigm, and particularly many of the treatments that are available, we're all familiar with them. I think it's a great paradigm for network teletrials, and I'd love to see the first myeloma study opened as a network trial.
We'll have one last question. I think it's from a healthcare professional, actually. It's from Adam. He says, "This looks fantastic, Prof. Is the network available to postgrad students conducting research?"
Absolutely. So I've had a lot of, that's something I haven't touched on. I've touched on more drugs and intervention studies because that's probably where I thought it was going to be most relevant for myeloma. But a lot of people have utilised this for epidemiological research, translational research, implementation science. So Adam, absolutely. This is really just a strategy that creates a network of connector points. And it means that whatever strategy you would be doing at your main site, you just deploy it to your network sites, and there's your growth. And Emma, I'm always happy to speak to anyone if people want to find out more about it or have got an idea, how would I execute this as a network teletrial? I'm more than happy to hear from people.
Perfect. Thank you so much, Kate, again, for your time today, and again for being such an advocate for our community in the regional, rural and remote setting. There are some questions that we didn't have time to answer today, but maybe we can contact you, Kate, if anyone has any questions, and we can get back to them potentially via email, or if they want to call the myeloma nurse support line with any questions as well.
Absolutely, Emma. Thank you so much for having me. And as I said, happy to follow up with anything that people are interested in.
Okay, thank you so much.
Take care.
So our next speaker that will be joining us is going to be speaking about the practical considerations of living with myeloma in the regional, rural and remote setting. So without further ado, I'd like to introduce our next guest speaker, Karen Young. So Karen is a nurse practitioner for cancer services in the Great Southern region of WA. Karen started out her nursing career at Royal Perth Hospital, where she discovered her passion for oncology and haematology, before travelling to England and Scotland, where she worked in specialist cancer and bone marrow transplant units at the Royal Marsden in London and the Western General in Edinburgh. When Karen returned to WA, she worked for 14 years as a cancer nurse coordinator for haematological malignancies within Metropolitan Health Services and spent also some time working as a myeloma support nurse for Myeloma Australia, based in WA. Karen made the move to regional nursing in 2020, where she started her current position as a nurse practitioner. Welcome, Karen.
Thank you so much for the invite from our little corner of the world over here in WA. I think, thank you for the introduction. It's a very kind introduction. I think what I, in this role, have come to understand, having worked both within Metropolitan Health Services and within regional health services, the disparity between care and access to care. So I feel very privileged to be in this position to, I guess, be a passionate advocate for country patients in accessing care, and especially with the myeloma population. So, yeah, thank you for letting me talk about this today. Next slide, please. So I think I can only really talk broadly from a WA perspective, and we probably have the largest country health service in the country, geographically certainly, probably not by population. And in having looked at some of the online, some of the health services nationally, they're all very similar. They're either divided into districts, health districts, or regions. In our case, we have 5 regional health services within WA Country Health. And within those, we have 5 resource centres or health campuses, and we have 5 chemotherapy units or centres that deliver chemotherapy to patients for both oncology and haematology. And we've also just started to set up our 3 telechemotherapy centres, which is really quite exciting. It's quite a new thing for WA. So patients as far as the Kimberley and the Pilbara can now access treatment closer to home in telechemotherapy sites, which are operated centrally with clinical staff centrally. So from my perspective, Albany is 4 to 5 hours drive from our nearest metropolitan centre in Perth, or an hour's flight. We are a level 4 hospital, so it means we pretty much do everything outside of ICU, and we can deliver chemotherapy here as well as a radiation oncology unit, which is coming early next year. So we're a fairly big centre when you look at it within health service, and certainly within health service in WA. We're no Albury Wodonga, but we're getting there. And just as a bit of a side note, we're the oldest settlement in the country, and this is where the Anzacs left from. So if you're ever over in this area, please come and see the Anzac Commemorative Centre. Next slide, please. So what are some of the challenges that are faced by patients who are diagnosed in regional areas? Well, firstly, delayed diagnosis. So when we look at myeloma, for example, so myeloma makes up about 1% of all cancer diagnoses. I mean, you think the top 5 are breast, colorectal, prostate, lung, and melanoma. They're the ones that GPs are traditionally looking out for. So there is a chance of a delayed diagnosis. We know that that's an issue for regional patients. There are also challenges with accessing specialist care and information. So for some areas, you have to travel to a nearest metropolitan area, which may be 2, 4, 6, 8 hours away for assessment in the very first instance. And even before we get to that point is accessing specialised diagnostic techniques. So things like PET scanning. For example, we can't do PET scanning here. We have to send patients to Perth to be able to access that PET scanning. Bone marrow biopsies, all those sort of key diagnostic things that we need to be able to diagnose myeloma and to monitor the disease. There's also, I guess, that challenge of accessing care closer to home. So if you don't have a nearest chemotherapy unit, or you are you are then having to spend prolonged periods closer to a treatment centre, and the cost and the impact of that. There can also be pathology delays. So we may do a QEP down here or a serum-free light chain, but that actually has to be sent to Perth to be processed. So there's also a delay in bloods and some other diagnostic, any sort of biopsies and things like that are not done locally here on site. We also, I think sometimes we underestimate the prolonged absences from home, not being able to work because you're effectively maintaining 2 houses, one in your residential area and one within the metropolitan area or close to the treatment centre. So that sort of financial and social impact. So not only having a diagnosis of a life-threatening or a life-changing disease, you're also facing these financial and social impacts and the isolation of all of that. Not everyone has somebody who can travel with them for treatment or for diagnostics in the first instance. So it has a significant impact on relationships and your social circle. And we know the top quote there is actually out of our WA Country Health Cancer Strategy. We have a cancer strategy which looks at improving care for cancer patients across WA Country Health. And we know that a significant number of patients will stop treatment because they live regionally, because of the accessibility to treatment. Next slide, please. So I've kind of divided this talk into care closer to home and care away from home because it was kind of the best way for me to look at it, really. So some of the strategies we have in a lot of centres now are things like telehealth and video conference consultations. So I think COVID has done us a massive favour in that regard because we're now becoming more familiar with the use of video conferencing and telehealth to be assessed by our specialist or to access healthcare. So I think that's been, if we're going to look at anything positive out of COVID, I think that's probably one of the big things. So here we have telehealth consultations very common with us here in our regional centre. We have one telehealth a week as well as one face-to-face site visit a week. So they're for haematology services here. There are downsides, and I've heard, telehealth can be a bit awkward. It's hard to assess a patient totally over the phone or via video conferencing. And interestingly, I have also heard from patients that sometimes they feel hurried in a telehealth appointment. That sort of, I know the consultant is busy and so he needs to get on to the next patient. So there's that feeling of feeling hurried in a telehealth. So I think there's probably a balance between alternating between telehealth and face-to-face kind of strategies for accessing care. The next one there I have is visiting or fly in, fly out haematology services, which is what we certainly have here. So once a week we have a face-to-face clinic, which I think is brilliant in the sense that you can, get to see your consultant face-to-face. They can do a physical assessment while you're here. And in our case, they alternate with telehealth. There are some downsides in that our consultants are here for a day. So they literally fly in and fly out. And so issues around communication, ongoing care is kind of a challenge of how we continue to manage your treatment locally. Reliability of flights. I don't know what it's like in the rest of regional Australia, but our airline provider here has been known to cancel flights, and there's been a mad rush to convert everything over to telehealth. So there are some challenges around the logistics of getting a fly in, fly out service. And I think the previous speaker mentioned about teleclinical trials, which we don't have operating yet on site here at Albany, but we're getting there. We've had a lot of talk around running teleclinical trials. So then we also have those strategies of local chemotherapy units and telechemotherapy units. So as I said earlier, we have 5 in Western Australia, WA Country Health. We have 5 chemotherapy units, which are staffed by skilled and knowledgeable staff, and they tend to treat both oncology and haematology patients. And we do have a significant number of myeloma patients that are travelling through our chemotherapy units for their injections for treatment. It's convenient. It reduces treatment burden of having to stay prolonged periods away from home. I think if you're on, say, RVD and you were having to travel to Perth once a week, that's a killer. That's 5 hours there and back once a week for anyone who's on that sort of treatment. We're not yet. We have discussed things around self-administration. We haven't sort of got to that point yet, but that's certainly coming in the future to help manage local treatment. And I think, and telechemotherapy I've also mentioned. So they're units which are run remotely with experienced clinical staff centrally in Perth. So we have one in Karratha, we have one in Broome, and we have one in Northam. And those are units which have pharmacy support, nursing support centrally to help manage those patients going into those units. So they don't see as many patients, but there's certainly another useful tool in getting treatment closer to home. And the key thing, I guess, around all of this is partnership with metropolitan hospitals. So we have 2 ways of providing care here. We have a link with a major teaching hospital in Perth, or we actually have we have consultants who are independently contracted to work for us here at the site. Oh, next slide, please. So I thought I couldn't go past showing some of the chemotherapy units. These are some examples of the chemotherapy units and telechemotherapy units we have here in WA. They're designated units, so they meet all the environmental standards and the appropriate protective equipment is used. And so it's a very safe environment. It's not a question of going into an emergency department and having it. It's actually a designated chemotherapy area with designated chemotherapy nurses and medical support to go with that. So the key thing about these units, though, is we tend to provide low risk regimes. So I think we can give any chemotherapy regime we like. I think we can manage hypersensitivities, but the key thing for anything given regionally is around how do we manage the side effects. So we don't have inpatient admissions here for haematology patients. So they are admitted under a medical oncology bed card, but if you come in with neutropenic sepsis, you are assessed by an emergency department doctor and often seen by the medical team, so not necessarily a specialist team. So we're very mindful of the regimes that we can provide here locally. There's no chance of us doing a stem cell transplant anytime soon. So I'm sorry if you're an Albany patient, but that's something that's not going to happen due to its high-risk nature and the need to have fairly urgent care, specialised care quickly. And as I said, we have low, we don't have inpatient admissions, so we can't admit to give chemotherapy. If patients are an inpatient and need to come, they'll come down to the day unit for treatment. And I guess the other challenge regionally is how we access our medications. So our medications come from a private provider externally, and if the truck breaks down and some of our treatments are delayed. We're lucky because the manufacturer we have does give a long life on a lot of drugs. So things like bortezomib, we're pretty safe. We can probably get your couple of weeks supply in one hit, but there are some logistics around that. And often we don't do some treatments on a Monday because of the accessibility and the delivery of drugs locally. Next slide, please. So who are some of the healthcare professionals that can help with this, with managing your care locally and also managing a transition to tertiary care if you need it? I think a key professional is care coordinators, so cancer nurse coordinators, navigators. There are various of these roles nationally, and we have cancer nurse coordinators locally here that cover all tumour streams. They're very good at identifying local resources for you, accessing care and how to access care in tertiary centres, tying up your scheduling of your appointments so you're not going on a Monday and then having to go back 2 weeks later. There's care coordinators are quite an invaluable resource from that perspective. Clinical nurse consultants and specialists on site or even in the tertiary centres, those are good at giving information and providing expert knowledge around treatment and diagnosis and side effects. And that includes the transplant coordinators. So our stem cell transplant coordinators will often liaise with the regional area about starting some of the workup for transplant. So, for example, we can start, we use GCSF as our workup for auto transplant, and we can start that here in the region so the patient's not having to travel to Perth for a prolonged period of time. I can't go past talking about nurse practitioners. That would be very remiss of me. So nurse practitioners, advanced practice nurses who have undertake assessment, prescribing and management of patients autonomously. Some of my work is around monitoring side effects from chemotherapy treatment, as well as follow-up post-transplant. So follow-up of bloods, side effects, revaccinations, those sort of things. So as a nurse practitioner, I have a greater amount of time to spend with you and to, link in with all those other things that are perhaps not covered, sort of a more holistic sense of care. We also use general practitioners a lot here. We rely on them to provide the ongoing healthcare for patients regionally and obviously scripts and things like that, though it has been difficult to get into your GP of late. Community pharmacies. So we have a very strong link with our local community pharmacies for accessing medicines. So a lot of our things like Revlimid are not dispensed through our hospital pharmacy here. They're actually dispensed through our community pharmacy. And we have a very strong link with that. Our regional pharmacist here provides those links. Allied health. So social worker is probably somebody who's very key in helping manage that transition or that ongoing care within regional WA and within the tertiary centre. They're very good at sort of financial assessments and linking in with local resources to help navigate your care, to take away that financial and social burden that diagnosis and having to travel for treatment can cause. And our allied health, occupational therapy, physiotherapy, dietetics, all of those here will link in with the tertiary centre and provide that ongoing care locally. Depending on how your regional centre is set up, we actually have cancer specific. So we have a cancer specific social worker and occupational and dietitian that works with us. So we they have very aware of some of the key aspects of care for patients undergoing treatment. And what I was very remiss to not put up there was palliative care. We rely a lot on palliative care for symptom support. I know that I frequently mention palliative care, and it does kind of lead people to think more about end of life. But in fact, we use them a lot for managing complex pain, complex nausea, which is not uncommon within patients with myeloma. Next slide, please. So what about care away from home? I think the key thing with care away from home is accessing any patient-assisted travel schemes that are available. There are varying types of those nationally. They will all have criteria. So here in WA, they're not means tested, and it's dependent on how far away you live from the treating centre. Or everyone is eligible to access those, and they will provide a subsidy for both accommodation and transport. And in our case, also an escort to stay away. We have a number of accommodation providers that provide accommodation that ensures you don't have an out-of-pocket expense. So they meet the subsidy scheme. So those pictures there, the top picture there is of Crawford Lodge, which is a Cancer Council accommodation on site at Sir Charles Gardner. We have Milroy Lodge, and the middle one there is actually Leukemia Foundation's accommodation, which is self-contained units, which a lot of patients can use while they're having transplant. We have a outpatient transplant scheme where patients can come in to Fiona Stanley for their transplant and back out again, and can actually stay in that accommodation, which is self-contained, and you can it's got kitchen facilities and things like that inside as well. There's also transport assistance in the form of Leukemia Foundation, some hospital volunteer transport as well. So all those sort of things. The social worker is very good, or welfare officer is very good at linking you in with those sort of resources that just takes some of the strain away from, having to navigate metropolitan traffic, which is terrible. And that's the reason why I moved down here. And to reduce some of the costs when we look at the cost of fuel and things like that. So they're a good social worker and welfare officer, very important. And of course, we have tertiary hospital providers. I don't know what's available nationally, but certainly we have limited accommodation provided at some of the hospital sites for short term. So there are other things if you need that sort of accommodation. Next slide, please. So I quite like this slide. I think that any care for regional patients is a team approach. And that's certainly what we use here. We have a number of healthcare professionals and resources that we can use locally to facilitate streamlined care, and also then to link in with the tertiary centre should you need it. I think what I want to make a note of here is there's some challenges with private providers. So if patients are seeing consultants privately through private facility and organisations, sometimes it's really difficult for the regions to access records and information. And if you're home and you present to the emergency department, we're not going to have that information. So there's some things that we struggle with on a day-to-day basis, that sort of having access to information about what people have had within the private sector. So some ways that we can maybe manage that is if you have a recent clinic letter, or you have a treatment diary that just tells us where you're at or who to contact should you need local assistance, medical assistance. We give our patients treatment diaries. So whether they're public or private, we give them a treatment diary to keep a record of their treatment regime and their side effects. So how do you know if you've got care closer to home? How do you know what's available? So I would say explore what you've got. So have a look on some of the country health websites, see what's available in each hospital, each district service. I would ask your clinician, can I have this done locally? Is this somebody I can refer? Can I have part of my treatment done locally? I think a big part of it is about asking the question. It's very easy as a metropolitan health provider to say, no, it's all given here, you get the best care here. But I think it's worth exploring, even if you can get part of your treatment. If so, what can I get locally? And I think there is this move to care closer to home. WA Country Health has a benchmark that it wants to see the majority of its patients, of its people treated closer to home. And we have set up a number of strategies, one being the nurse practitioner, to try and facilitate that a bit more. So I'm very passionate that we see more treatments being given close to home, and certainly myeloma patients. Last slide. And does anyone have any questions?
Thank you so much, Karen. You've actually answered majority of our questions that were asked in our regional, rural and remote survey, so that's great. We do have time for one question, however. How do I access my whole team? So my nurse, allied health, etc., and haematologist in the rural and remote setting? So
I guess I'll speak from the WA perspective. So I think for us, the key member is actually the nurse coordinator. So how it works through here, our nurse coordinator is linked with every new referral that comes through this centre, and also we kind of tie into the tertiary centre as well. So I think that's probably the key way. As a nurse practitioner, I would say contact your nurse practitioner, because we certainly link in with everyone. But I think care coordinator, your chemotherapy nurse, that might be another way. That's kind of so from my perspective, we link into multidisciplinary teams and things like that. So we have a very close working relationship with the haematologist and the nursing and the allied health team. So I would use your care coordinator or your navigator as your first port of call, or your admitting nurse, your outpatient nurse. Ask them what's available.
We'll have time for one more quick question. It's from Adam. He says, hello, Karen. Nurse practitioners have shown to be incredibly valuable in the Heme-Onc multidisciplinary team, but they are so thin on the ground. How can we entice or incentivize nurses to train as nurse practitioners and then work in rural and remote locations?
So I've thought a lot about this. I think the key thing is advertising. So, for example, me doing a presentation like this and being ready to talk all the time about the role and how the role changes things. We need to present things. We need to present things at conferences and a national level about what the impact is that a nurse practitioner has on patient care. And I think there probably needs to be some stuff higher up where we are offering traineeships or incentives to do your nurse practitioners. So, for example, I self-funded my studies. I did all that in my own time. So I think there needs to be an incentive or a trainee program to encourage people. And I think at this point in time, we actually need accommodation for people to come and stay in the regional areas. That there's some practicalities around that. But I think advertising and, if anyone is out there that wants to come and spend some time with me, I'm more than welcome to show them how we function here in the Great Southern. It's the best job I've ever done, and it's my dream job. So I can't say any more.
Thank you so much again for your time, Karen.
Thank you.
I'll pass over now again to Tash, who's going to introduce our last speakers, who are community members of Myeloma Australia.
Thanks, Emma. That was great, Karen. Thanks for hear the benefit of your experience over time. I now want to introduce Alan and Roz. Alan and Roz come from rural New South Wales. They are great example. Alan today came back from his treatment, an hour and a half drive from Tamworth, to be with us today. So I look forward to asking them questions. Hi, Alan and Roz. How are you today?
Are you hearing us okay?
Yes,
Hello.
we are. Yeah.
Okay, thank you.
Hi.
Hi. So, guys, just tell us a little bit about yourself, where you live and your myeloma journey and where you're treated, that kind of stuff.
Right. Well, I'm a farmer. I live in northwest New South Wales on the famous Liverpool Plains. Many of you may have heard of that area. Yeah, I'm still wouldn't class that as remote by any means. It's a rural area. I'm still trying to work, and not near as active as I used to be, but I'm still managing to do a bit of work.
That's great. And
sorry.
That's okay. Keep going.
Yeah, and I was diagnosed with this horrible disease back in about 2009. So I've been through many treatments since then, and still alive and kicking. Had 2 bone marrow transplants, and then a lot of support treatment with chemos and stuff like that up to date, and everything seems to be working okay. Probably the biggest problem is side effects, more so than the actual disease itself. There's a lot of side effects from all the treatment, but just something you've got to live with.
Yep. And is your local health service, like your GP or your local hospital, really supportive for those side effects?
Well, they don't have a lot of answers other than cutting back on the amount of the dosage of some of the treatments. Other than that, they don't seem to have too many answers for side effects, really. But reducing the treatment has to be managed very carefully, though. Otherwise, it starts to lose its effectiveness if you go too far with that.
Yeah.
Yeah,
and guys, what would you
I'd say on that initially our GP, it took a while to diagnose Alan to start with. He was treated for all sorts of things before they came up with the diagnosis of that he actually had myeloma to start with. And that then started the whole roller coaster, I suppose, straight to St Vincent's Hospital for treatment in Sydney, which is sort of 6 hours away for us. It was a time that we had, I felt there we were very lost in a big place. But in recent years, we've had a cancer centre built and created in Tamworth, which is only an hour and a half away, which has made our journey much closer and much easier by being able to just to go to Tamworth opposed to travelling to Sydney for the ongoing treatment. But we do always like a second opinion. We've been involved with Feed and Mac in Melbourne. And you've got to push to get to these places for second opinions. And I felt that is really important because there's new advances happening all the time. And until you actually do the research online as much as we could, we looked at Google, then Google Scholar, and just a lot of research from rural, which we didn't actually get those options, I suppose, put to us from our local support network. We sort of went out and found it ourselves, and then I had to start asking the questions and pushing to get answers or options and information, I suppose, is the word I'm looking for.
Yeah. So you felt like you had to be your own advocate.
Very,
Yeah, very much so.
yeah, very,
And,
very much so.
I think it's the only way to get the best treatment, really.
Yeah. And so what's been the hardest part, apart from, having to advocate for yourself, what's been the hardest part about living with myeloma in your rural setting?
Oh, well, I guess just accessing the treatment, that really, it's just become part of our life now. We don't even think twice about it now. We know every Wednesday I've got treatment. Our week revolves around that. So it's just become part of our routine now. We don't even think about it as much.
Yeah. And I suppose really rural doctors, as wonderful as it is, but we felt at one stage a doctor gave up on Alan and basically said, go home, make sure your affairs are in order. And that was
4 or 5 years ago.
And we just said, no, that's not it. And we're going out to find somebody else. And here we are, sort of 4 years on. And sometimes because there isn't, we only have fly-in, fly-out doctors, basically. And you've got to sometimes push to sort of say, hey, we deserve better than that. And you've got to do it. And getting then the professionals to talk to your local doctor, that was also a bit of a challenge for quite some time. But now we pursued that, and now we know that everything goes from our treating doctor who flies in to our backup doctor at Peter Mac, I suppose, our consult doctor at Peter Mac in Victoria, which has been wonderful since it's happened.
That's great. So I guess we have to close now, but as a closing statement, it sounds like you've got a lot of strength there to have lived with myeloma for so long. Where do you draw that strength from?
I guess it's just part of my nature. If you're a farmer, you've got to have a lot of inner strength. So I guess I've got a very optimistic outlook on life, and I'm not one to ever give up. So whenever there's life, there's hope, and I just keep pushing on. And I'm quite happy to research my own treatments and learn as much as I can about the disease, and always looking for the next line of treatment that's coming down the line. And
And not be afraid to ask questions. If you get told no, well, why not? Why can't we explore this? Don't be afraid to ask questions. And as Alan said, he's just resilient, and do as much research as you can, and don't be afraid to ask the questions to your doctors. And if you're not lucky enough to get regular nurses, which are wonderful at the Cancer Centre, but don't be afraid to ask questions and become informed of yourself.
I think they are fabulous, inspiring words, and thank you so much for giving up your time and making the effort to get back from your treatment centre to be with us today. I think many patients will gain a lot of inspiration from you. So thank you all for joining us today. Thank you all for joining us today. I'd just like to point out that at the bottom of the screen, if you scroll down, there's an evaluation. We really appreciate your feedback. So if you could fill that in, that would be great. And that helps us improve our programs as we go along. And I took a lot of people to bring today together. There was Narelle in WA, Jackie in New South Wales, EJ, Emma and Nella in Victoria, and especially thanks to CVP, who are the production company who provide us with our webinars while we're here. If you've got any more questions, please feel free to either put them in the chat now, or when the chat closes, you can always email nurses@myeloma.org.au, or you can call the support line Monday to Friday, 9 to 5. Thank you very much. Bye.